Good day, everyone. Today's lecture will be on nerve injury. We will be talking on the classification of nerve injury. Then we will discuss on the process of Wallerian degeneration and nerve repair and regeneration. We will also be talking on the treatment of nerve injury, the complication, outcome, and prognosis. So peripheral nerve lesions are frequent occurrence in human, leading to important physiological and labor complications that affect the quality of life of those suffer the injury. Most severe injuries are often associated with poor nerve regeneration and inadequate functional recovery, even with the early medical and surgical intervention. Its clinical relevance is high since the peripheral nerve is much more frequent and undervalued than spinal cord injuries. The causes of nerve injury are multiple and distinct and may include traumatic events or results from iatrogenic intervention, mostly medical or surgical. Loss of motor, sensory, or autonomic function in the denervated body segments is the main consequence associated with this type of injury and usually entails to severe functional deficits. Nerve injury may involve axonal loss, myelin loss, or commonly a combination of both. Clinically, it may lead to sensory dysfunction with possible motor loss. Functional recovery entails axonal regeneration, occurring at the rate of 1 to 2 millimeter per day, and remyelination with reinnervation of sensory receptors, neuromuscular junction, or both, and it may take days to months depending upon the distance the axon has to travel. Children recover earlier than older subjects, as the axons have to travel less distance to reinnervate the regional muscles. The nervous system has two main parts, the central nervous system and the peripheral nervous system. The central nervous system is made up of the brain and the spinal cord, whereas the peripheral nervous system is made up of the cranial nerve and nerve that branch out from the spinal cord and extend to all parts of the body. The basic unit of the nervous system is a nerve cell, or also known as neuron. A neuron has a cell body, axons, and dendrites. Bundles of axons is called nerve. Axons and dendrites allow neurons to communicate. The nervous system allows us to perceive, understand, and respond to our environment. It comprises two different types of cells, the nerve cell and the glial cells. The nerve cells or neurons, these form the functional basis of the nervous system, responsible for transmitting signals as electrical or chemical signals. Glial cells, on the other hand, are those provide functional and structural support for the neurons. Examples are Schwann cells, which produce the lipid sheath in the peripheral nervous system, and the oligodendrocyte in the central nervous system. So what is the function of glial cells? Glial cells help to support and hold neurons in place. It also protects neurons. It also creates insulation known as myelin, which helps move nerve impulses. Glial cells also help to repair neurons and help to restore neuron function, and it also involved in the regulation of the neurotransmitter. Now let us look at the neuronal structure. There are several different types of neurons found in the nervous system. They all contain the same key structural components, which are the cell body, dendrites, the axon, and the axon terminals. The cell body holds the nucleus. It is the site of protein synthesis, which occurs on the small granules of rough endoplasmic reticulum called Nissl substance. In the nervous system, many neuronal cells body can group together to form a distinct structure. In the central nervous system, this is known as a nucleus, and in the peripheral nervous system, it is known as a ganglion. The dendrites are elongated portion of the cell body. They extend upwards, receiving input from the environment and form other neurons. The axon is a long, thin structure down which action potential are conducted. Whilst neurons have many dendrites, most cells only have one axon. Each axon is coated in myelin, which is a layer of insulating lipid. Myelin is formed by cells wrapping themselves around the nerve axon. In the central nervous system, this is performed by oligodendrocyte cells, whereas in the peripheral nervous system, the Schwann cells are responsible for this action. There are gaps between the myelin sheath forming by different cells. These gaps are known as nodes of Ranvier. They allow for saltatory conduction of impulses. The axon terminal is the most distal part of the axon. It is from here that the neuron sends chemical signal to other cells, usually via neurotransmitter release. To facilitate the secretion of neurotransmitter, the axon terminals contain a large number of mitochondria. So this is a nerve cell or neuron of the peripheral nervous system. Now we have the nucleus, the axon with the myelinated sheath and the axon terminal. In between the myelinated sheath, we have area of unmyelinated, which is known as node of Ranvier. And the glial cells which surround the axon is known as the Schwann cell. This is the neuron or nerve cell for the central nervous system. The basic structure is the same except for the presence of oligodendrocyte instead of Schwann cells, which which protect the axon. So in the central nervous system, the glial cell is known as the oligodendrocyte, whereas for the peripheral nervous system, the glial cell is known as the Schwann cell. The axons are enclosed by several connective tissue layers. We have endoneurium, perineurium, and epineurium. Endoneurium surrounds the axon of an individual neuron. Perineurium, on the other hand, surrounds a fascicle, which is a collection of neurons. And epineurium surrounds the entire nerve, which is formed by a collection of fascicles. Epineurium contains numerous small blood vessels which supply the nerve fibers. Epineurium appears on the nerve as it exits the intervertebral foramen. It is created by the fusion of arachnoid and pia mater, which are layers of the meninges. So this is a cross-section of the nerve. So we can see the basic component of nerve, which is neuron, surrounded by the endoneurium, and the perineurium surrounded a fascicle, which is a collection of neuron, and the epineurium surrounds the collection of fascicles. So how do we classify neuron? Neuron can be classified by structure or by function. Neurons with different functions have different structures, which is visible histologically. Structural classification of neuron is based upon the number of processes that extend out from the cell body. Structural classification can be divided into unipolar, pseudo-unipolar, bipolar, and multipolar neuron. For unipolar neuron, the cell body is at one end of a single unbranched axon, and there are no dendrite, meaning this is a single long axon neuron. The axon in unipolar neurons is myelinated, which allows for rapid signal transmission. This can be found in the cochlear nucleus of the brain. Pseudo-unipolar neuron. These have one axon which is divided into two branches by the presence of the cell body. This neuron contains an axon that has split into two branches. One branch travels to the peripheral nervous system and the other to the central nervous system. Sensory neurons are all pseudo-unipolar. Bipolar neurons are neurons which have two processes arising from a central cell body, typically one axon and one dendrite. These neurons send signals and receive information. Example of these are cells that are found in the retina. And multipolar neurons are those which have one axon and many dendrites, with a cell body displaced to one side of the axon. These neurons are able to receive impulses from multiple neurons via dendrites. Motor neurons are a prime examples of this. Functional classification of neuron. There are three broad functional classification of nerve: sensory, which is afferent, intermediate, and motor, which is efferent. There are key structural differences between these three types. Sensory nerve has small axons and pseudo-unipolar structure, whereas motor nerve has larger axons and multipolar structure. Uh, the intermediate neurons has central cell body and many dendrites. Sensory and motor nerve are located within the peripheral nervous system, whereas intermediate nerve are found in the central nervous system. Now let us look at nerve. In 1943, Sir Herbert Seddon described the three basic types of nerve injuries and referred to them as neuropraxia, axontomesis, and neurotmesis. Later in 1951, Sunderland further elaborated Seddon classification. The Seddon and Sunderland classification have been used by physicians for peripheral nerve injury grading and treatment. While Seddon classification is simpler to follow and more relevant to electrophysiologists, the Sunderland grading is more often used by surgeons to decide when and how to intervene. Let us look at neuropraxia. What is neuropraxia? This is the mildest type of peripheral nerve injury. Neuropraxia is a temporary interruption of conduction without loss of axonal continuity. There is a physiological block of nerve conduction in the affected axon. In neuropraxia, there are sensory motor problems distal to the site of injury. The endoneurium, perineurium, and the epineurium are intact. There is no Wallerian degeneration in neuropraxia. The conduction is intact in the distal segment and proximal segment, but no conduction occurs across the area of injury. Prognosis of neuropraxia: recovery of nerve conduction deficit is full, meaning complete recovery, and requires days to weeks to recover. Axontomesis involve loss of the relative continuity of the axon and its covering of myelin, but preservation of the connective tissue framework of the nerve. There is the encapsulating tissue. The epineurium and the perineurium are preserved. In axontomesis, Wallerian degeneration occurs distal to the site of injury. There are sensory and motor deficit distal to the site of lesion. There is no nerve conduction distal to the site of injury. Axonal regeneration occurs and recovery is possible without surgical treatment. Sometimes surgical treatment is required due to scar tissue formation. Prognosis for axontomesis: the recovery is unpredictable. Next is neurotmesis. Neurotmesis is a total severance or disruption of the entire nerve fiber. Wallerian degeneration occurs distal to the site of injury. There is connective tissue lesion that may be partial or complete. In neurotmesis, sensory, motor problems, and autonomic function defect are severe. There is no nerve conduction distal to the site of the injury. Because of lack of nerve recovery, surgical intervention is necessary. Prognosis of neurotmesis: there is no recovery unless surgical repair is performed. And neuromal formation at proximal nerve end may lead to chronic pain. Okay, let us discuss about the classification of injury. Two classification has been used, Seddon classification and Sunderland classification. As mentioned before, Seddon classified nerve injuries into three major groups, neuropraxia, axonotmesis, and neurotmesis, whereas Sunderland expanded Seddon's classification to 5 degrees of peripheral nerve injury. Classification of nerve injuries is useful in understanding their pathological basis, making decisions on management, and predicting the prognosis for recovery. So this is Seddon's classification. We have neuropraxia, axonotmesis, and neurotmesis. In neuropraxia, there is a temporary paralysis of a nerve caused by lack of blood flow or by pressure on the affected nerve with no loss of structural continuity. In axonotmesis, the neural tube is intact but axons are disrupted. Nerves are likely to recover. In neurotmesis, the neural tube is severed. Injuries are likely to be permanent without Seddon classification has a limitation. Yeah? In Seddon classification, it doesn't distinguish between all grades of intraneural damage. Yeah? Lesions classified as axonotmesis have been observed to have variable recovery. This is because variable degrees of damage to the connective tissue layers of the nerve, including the endoneurium and perineurium, as well as disruption of the axons, are possible without loss of continuity of the nerve trunk. So this is the Seddon classification. We see the intact nerve, nerve with neuropraxia, where you have a conduction block. Here is axonotmesis, and here we have neurotmesis, total severance of the nerve. So Sunderland later described 5 degrees of injury to a nerve. This is based on increasing anatomical disruption of the nerve trunk and distinguishes injuries where the nerve trunk is in continuity but there is damage to the endoneurium and the perineurium. Sunderland's observation suggested that there is likely to be recovery, although variable, in cases of third-degree injury where the endoneurial tubes are damaged but the perineurium is intact. But that useful recovery is unlikely for fourth-degree injuries where the perineurium is disrupted. So this is Sunderland classification. First degree, class 1, is similar to Seddon's neuropraxia. Second degree, class 2, is similar to Seddon's axonotmesis. Third degree, or class 3, third degree is included within Seddon's neurotmesis. Sunderland's third degree is a nerve fiber interruption. In third degree injury, there is a lesion of the endoneurium, but the epineurium and the perineurium remain intact. Recovery from a third degree injury is possible, but surgical intervention may be required. Fourth degree, class 3, fourth degree is included within Seddon's neurotmesis. In fourth degree injury, only the epineurium remain intact. In this case, surgical repair is required. And Sunderland fifth degree or class 3, fifth degree is included within the Seddon's neurotmesis. In fifth degree lesion, there is a complete transection of the nerve. Recovery is not possible without an appropriate surgical treatment. So this is to show a combination of Seddon and Sunderland classification. Seddon neuropraxia is similar to grade 1, and Sunderland axonotmesis can be divided into Sunderland grade 2, 3, and 4, whereas Seddon neurotmesis can be classified into grade 5, Sunderland grade 5. So you can see for neuropraxia or grade 1 Sunderland classification, there is a focal segmental demyelination injury, and there is a spontaneous recovery. Nerve conduction, there is a partial or complete conduction block proximally, but preserved conduction block distally even after 2 weeks of injury. In axonotmesis or Sunderland class grade 2, there is injury or damage to the axon with intact endoneurium. Recovery is slower than neuroplexia. For Sunderland grade 3, injury, there's damage axon, and the endoneurium, there's injury to the axon and endoneurium with intact perineurium. Recovery is not very likely. Surgical intervention may be needed. In Sunderland grade 4, there is injury to the axon, endoneurium, and perineurium, but the epineurium is intact. Spontaneous recovery is highly unlikely unless unless there is a surgical intervention. For Seddon axonotmesis and Sunderland grade 2, 3, and 4, in terms of nerve conduction, there's partial or complete conduction block proximally. There is preserved conduction block distally until Wallerian degeneration sets in. And for neurotmesis or Sunderland grade 5, there is complete nerve transection, meaning there's disruption of the myelin sheath, axon, endoneurium, perineurium, and epineurium. For spontaneous recovery, there is no spontaneous recovery unless surgical intervention is performed. In terms of nerve conduction, complete conduction block proximally and distally. Now let us look at the causes of nerve injury. There are multiple or many causes of nerve injury. The nerve can be injured by traumatic injuries, which is, for example, caused by stretching, compression, crush, or cut nerve. Nerve also can be injured due to infection, for example, Lyme's disease, shingles, Guillain-Barré syndrome, infection with Campylobacter jejuni, Ramsay-Hunt syndrome, which involves the varicella zoster virus. Okay. Nerve also can be injured due to metabolic problem, for example, in diabetes mellitus. Inherited causes also possible for nerve injury, for example, in Charcot-Marie-Tooth disease, which affect the motor and sensory nerve. Prolonged exposure to toxin can also cause nerve injury. For example, exposure to organic solvent such as aromatic cyclic alcohol, ester, ether, and ketones. Exposure to heavy metals also can lead to nerve injury. For example, exposure to arsenic, lead, and mercury. Tumor also can cause nerve injury. For example, parotid tumor, tumor at the auditory canal, or neurofibromatosis. Another cause of nerve injury is iatrogenic causes, for example, surgical or pharmacological. Okay. And the other cause of nerve injury is idiopathic. For example, carpal tunnel syndrome, where there is idiopathic compression of the median nerve. What is the complication of nerve injury? We can divide into motor neuropathy and sensory neuropathy. Under motor neuropathy, we may have muscle cramps, twitching, muscle weakness, foot drop, muscle wasting, and paralysis. Complication under sensory neuropathy, there could be a decreased sensation of vibration and touch. There's pin and needles and hypersensitivity. There's increased pain or inability to feel pain. There will be loss of ability to detect changes in heat and cold. There will be difficulty with coordination and balance. And there will also be burning, stabbing, lancing, boring, or shooting pains, which may be worse at night. So in general, nerve injury complication can lead to pain, numbness, and tingling sensation, muscle weakness, nausea and vomiting, dizziness, and lightheadedness. So in patients suffering from neuropathic pain, the perceived pain is usually spontaneous, manifesting itself without needing a stimulus. Among the signs and the symptoms connected to the presence of neuropathic pain are allodynia, which is pain due to stimulus that does not normally provoke pain. Uh, there can also be hyperalgesia, which is an increase in the perception of pain generated by a stimulus that causes pain, and there can also be paresthesia, a condition that determines the perception of anomalous sensation comparable to needle bites, tingling, itching, reduced, or even loss of sensitivity. How do we diagnose nerve injury? Peripheral neuropathy has many potential causes. The diagnosis and precise location of the peripheral nerve lesion are based on the clinical history and the physical and neurological exam of the injured individual. A full medical history is important. We need to review the medical history, including the symptoms, lifestyle, exposure to toxin, drinking habits, and a family history of nervous system disease. We need to do a neurological examination. We need to check the tendon reflex, the muscle strength and tone, the ability to feel certain sensation and posture and coordination. So what are the investigation that need to be done? Blood tests, which can detect vitamin deficiency, diabetes, abnormal immune function, and other indication of condition that can cause peripheral neuropathy. We need to do imaging tests, for example, CT scan or MRI, which we can look for compressed nerve, tumor, or other abnormalities affecting the blood vessels and the bone. We also need to do electromyography, nerve conduction study, pain assessment, sensation deficit and skin condition test. We need to do the muscle strength or loss test and functional deficit test. Okay, now let's discuss the process of Wallerian degeneration. Wallerian degeneration refers to the well-orchestrated morphologic and biochemical changes that occur in axon, Schwann cells, and macrophages distal to a site of nerve injury, resulting in the establishment of a microenvironment supportive of axonal regeneration. This active process results in fragmentation and disintegration of the distal segment of the axon. Debris is removed by glial cells and macrophages. Proximal axon regenerate and re-innervate their target, allowing recovery of function. There are three stages: axon degeneration, myelin clearance, and regeneration. So what happens in nerve injury? When a nerve axon is severed, the end still attached to the cell body is labeled as the proximal segment, while the other end is called the distal segment. Injury to the peripheral nervous system immediately elicits the migration of phagocytes, Schwann cells, and macrophages to the lesion site to clear away debris such as damaged tissue, damaged tissue of the myelin residues. There will be rapid removal of myelin, speed up axonal repair. After injury, the proximal end swells and experiences some retrograde degeneration. But once the debris is cleared, it begins to sprout axons and the presence of growth cones can be detected. Wallerian degeneration ensues 24 to 48 hours. Structural axonal durability is lost between 48 to 96 hours after injury, and conduction of impulse ceases. Myelin disintegration lags slightly behind that of axon, but is well advanced by 36 to 48 hours. Schwann cells and macrophages work together to clean up the injury site, which may take 1 week to several months. The other significant role of Schwann cells is to complete the clean endoneural tubes in organized longitudinal columns defined as Buckner's brand, which is important guides for sprouting axons during regeneration. The proximal axons are able to regrow as long as the cell body is intact and they have made contact with the Schwann cells in the endoneural channel or tube. The distal segment undergoes Wallerian degeneration within hours of the injury. The axon and myelin degenerate, but the endoneurium remains intact. In the later stage of regeneration, the remaining endoneural tube directs axon growth back to the correct targets. To repair, axon must have the inherent ability to grow. The distal environment must support the growth again, and the target tissue must accept new axons. During Wallerian degeneration, Schwann cells grow in ordered columns along the endoneural tube, creating a band of Buckner that protects and preserves the endoneural channel. Macrophages and Schwann cells release neurotropic factors that enhance regrowth. Distal damage is better than proximal damage due to the need for shorter distance to reach their target tissue. So this summarizes the Wallerian degeneration. We have nerve injury. So at the distal segment, there will be axon degeneration and the myelin shift. The macrophages, the monocyte and the Schwann cell will phagocytose all the debris, and the Schwann cell also later will proliferate, and will arrange in an ordered manner to form band of Buckner. And the axon will start to regenerate the axon sprout. And later this axon sprout with the orientation of the band of Buckner will reattach to the target tissue, for example, the targeted muscle. And then that will allow for the nerve regeneration. The Wallerian degeneration in peripheral nervous system and central nervous system differ with respect to the types of cell involved and the outcome. In terms of the type of cells involved, Schwann cells and macrophages are involved in peripheral nervous system, whereas oligodendrocyte and microglia involved in central nervous system. The outcome in peripheral nervous system, there is removal of degenerated myelin, whereas in central nervous system Wallerian degeneration, there is no removal of degenerated myelin. So unlike peripheral nervous system injury, injury to the central nervous system is not followed by extensive regeneration. It is limited by the inhibitory influences of the glial and extracellular environment. Transforming growth factor beta 1 and 2, interleukin and cytokines are released and initiate the glial cell scar formation. This glial scar significantly inhibits nerve regeneration, thus lead to a loss of function. The accumulation of reactive astrocyte at the site of injury also contribute to the failure of neuroregeneration in the central nervous system. Slower degeneration of the distal segment than that which occurs in the peripheral nervous system also contribute to the inhibitory environment because inhibitory myelin and axonal debris are not cleared away as quickly. All these factors contribute to the formation of glial scar, which axon cannot grow across. The proximal segment attempts to regenerate after injury, but its growth is hindered by the environment. So this summarizes the whole process of Wallerian degeneration in the peripheral nervous system. We have nerve injury, then the nerve will begin to degrade at the distal end. The axon and the surrounding myelin start to break down. The macrophages and the Schwann cell will start to phagocytose the tissue debris. The connection with the target muscle is lost, leading to muscle atrophy and fibrosis. Then there will be axon sprouts with a finger-like growth cone advanced using the swan cell as a guide. Then the newly connected axon matures and the pre-injury cytoarchitects and functions are restored. So this summarizes the whole process of Wallerian degeneration in peripheral nervous system. Okay, sometime when there is a scar or the gap between the injured tissue is too far, there will be an unsuccessful attempt of nerve regeneration. Okay, let us look at the nerve regeneration. Neuroregeneration or nerve repair refers to the regrowth or repair of nervous tissue, cells or cells product. This may include generation of new neurons, glia, axon, myelin or synapses. Differs between the peripheral nervous system and the central nervous system by the functional mechanism, especially the extent and the speed of recovery. While the peripheral nervous system has an intrinsic ability for repair and regeneration, the central nervous system is, for the most part, incapable of self-repair and regeneration. Repair is achieved through regeneration of severed axons and re-innervation of the target tissues. Successful functional recovery depends on the ensemble of cellular and molecular events that develop distal to the lesion site all the way towards the denervated target. So during Wallerian degeneration, swan cells grow in ordered columns along the endoneural tube, creating a band of Buckner cells that protects and preserves the endoneural channel. In the later stage of regeneration, the remaining endoneural tube directs axon growth back to the correct targets. Macrophages and swan cells release neurotrophic factor that enhance regrowth. The human axon growth at the rate that can reach 2 millimeter per day in small nerve and 5 millimeter per day in large. So treatment can be divided into medical and surgical. Wherever possible, pharmacological treatment should be preferred over surgical intervention. Various pharmacological agents have been used and described as effective in stimulating or improving nerve regeneration after injury. For example, treatment for neuropathic pain. The first line of treatment for neuropathic pain is the use of anticonvulsant and antidepressant drug. We can use nortriptyline, amitriptyline, carbamazepine, and gabapentin. Second line of treatment is the use of opioids, for example, tramadol. Neurobion and vitamin B complex can also use to treat neuropathic pain. This can help to improve nerve function, reduce neuropathic pain, and promote nerve regeneration. We can also use serotonin, norepinephrine reuptake inhibitor, for example, duloxetine and venlafaxine. These will relieve neuropathic pain. We can also use corticosteroid, which can minimize swelling and pain. And the use of magnesium ion is also indicated. This possesses a good neuroprotective properties and it allows nerve regeneration promoting effect. It allows nerve regeneration promoting effect. There are also medication that offer short-term pain relief. For example, injection of medication into the area near a nerve or group of nerve can be more effective than oral medication because the medication is delivered directly to the part of the body that is in pain. Steroid injection may reduce the inflammation and irritation to that nerve and reduce pain. Local anesthetic may also break the cycle of pain and provide some relief of the patient's chronic pain. Opioid injection also provide powerful short-term pain relief. We can also do what we call longer-term nerve block. In severe cases, a type of nerve block that damage or destroy certain nerve is considered. The goal uh, is to prevent pain signal from reaching the brain. Example of this neurolytic block, which use injection of chemical or cryogenic freezing, which involve extremely cold temperature to damage part of the nerve. You can also use radio frequency ablation or neurotomy, harnesses radio wave to send electrical current to create a lesion on certain nerve. We can also do a surgical nerve block, involve a neurosurgeon removing or damaging specific part of a nerve or nerve. For example, peripheral neurectomy in trigeminal neuralgia. We can also try radiosurgery, radiosurgery which deliver concentrated radiation to destroy the nerve. Okay, the second mode of treatment is surgical or surgery. Surgical involve direct nerve repair. Direct nerve repair is performed with microsurgical technique. Is still a gold standard treatment method for axontomesis and neurotomesis injury. We can do a primary end-to-end repair. Here, there will be reanatomosing of the severed nerve. The nerve ends are mobilized and brought together, leaving a minimal gap by applying appropriate tension. Tensionless repair have shown to have better outcomes. During the approximation, the nerve ends can be mobilized, but extensive intravascular dissection should be avoided. The epineurium is sutured with 9O or 10O suture. This is example of end-to-end anastomosis or repair of the nerve. The other way of how to surgically repair a nerve is to do a nerve grafting. This is indicated when the defect between the two nerve ends may be too large or cause inappropriate tension for end-to-end repair. We can use autologous sensory nerve, for example, the medial or lateral antebrachial cutaneous nerve or lateral femoral cutaneous nerve. Nerve should be grafted within 6 months to achieve full recovery. And we need to harvest 10 to 20% longer than the measured defect to allow for contraction. And 40 to 50% of patients who undergo nerve grafting achieve notable functional improvement. Okay, here we can see the use of great auricular nerve as a graft for the facial nerve repair. We can also use fibrin glue. Fibrin glue enables primary sutureless repair with an adhesive. Repair with fibrin sealant ensures shorter recovery time, less fibrosis, and decreased inflammatory reactions. We can also use nerve conduits. Nerve conduits serve as a bridge between the proximal and distal stump of the injured nerve and provide a scaffold for axonal regeneration. This provides an ideal microenvironment for neuronal recovery. Nerve conduit is categorized according to materials as biological and synthetic conduits. Biological nerve conduits include autologous arteries, vein, umbilical cord, and umbilical cord vessels. Synthetic nerve conduits include silicone, elastomeric hydrogel, and porous stainless steel, which is non-degradable. We can also use degradable conduits such as collagen, polyester, polylactic acid, and hydrogel. This is an example of nerve conduit. Okay, we can also perform nerve decompression. For example, in the case of tunnel carpal syndrome, compression of the median nerve the nerve can be decompressed. We can also perform massage, for example, in aromatherapy massage. Study has shown that this helps to manage neuropathic pain and improve quality of life. We can also do a transcutaneous electrical nerve stimulation, TENS. Yeah? The application of TENS has been found to be of benefit in pain reduction in neuropathic pain. It was found to be of benefit if used at 100 Hz in constant mode. We can also use low-level laser therapy, LLT. Studies have found that this to be of benefit in pain relief and acceleration of healing in treatment of neuropathic pain and neurological deficit as adjuvant therapy. We can also try relaxation technique, and finally we can also try acupuncture in the treatment of nerve injury. So in conclusion, traumatic peripheral nerve injuries are always a challenge to the clinician. A successful management of nerve injury requires the understanding of the thorough knowledge of anatomy, pathophysiology of nerve injury, and reconstructive option. The classification of nerve injury help the clinician in the management and treatment of peripheral nerve injury. I thank you.